Good morning, everyone, and welcome to the November Air Quality Health Task Force meeting. For those who don't know me already, I am Nick Van Hazen, and I'm an air quality planner at the North Central Texas Council of Governments. So as a quick overview of the task force for anyone new, the task force is a collaborative effort that was implemented in 2019 at the request of the local governments for looking into for better understanding of health-related air quality impacts and pollution. So the task force is comprised of government and academic representatives, health officials, and air quality experts. We meet quarterly in order to exchange information and address concerns over localized air pollution. And we go into it with a focus and a vein of transportation-related sources. So I'll go ahead and pull up the agenda really quickly, and from there we'll get on with the first presentation. So first up, we have Dr. Timothy Bray from University of Texas at Dallas. He will be discussing the Texas inpatient health data. This is one of the health data sets that Dorothy briefly talked about last meeting, and we are really excited to actually hear about this, as this is something that we are hoping to further explore in the future to kind of help us with this health data. As most of y'all know, getting health data is kind of a pain. So without any further ado, I'll go ahead and stop sharing my screen and let Dr. Bray go ahead and share his and present for us.
Thank you, Nick. Let me get my screen to pop up here. There we go. And click share, and the world will be happy. All right, so good morning, everybody. As Nick mentioned, my name's Tim Bray. I'm at the University of Texas at Dallas at the Institute for Urban Policy Research, which is in our School of Economic, Political, and Policy Sciences. We, in our school, are at what we call the intersection of people, place, and policy, right? This is the idea that policies are great, but people have to enact them, and they affect different places differently. I think air quality is a great example of something that people assume to be universal, but is actually fairly specific in how it impacts people in place. So today I want to talk a bit about the Texas inpatient hospital data, which has been collected in Texas for quite some time. It began, and let's see if we can get this clicker to work. There we go. Began in 1995, right? So we were watching Frasier, the Drew Carey Show, Homicide, Life on the Streets, Michael Chiklis in The Commish before he became the other guy in The Shield and ER. And in 1995, the 74th Texas legislature passed House Bill 1048, signed by Governor George Bush. It created the Texas Healthcare Information Council, and directed that they develop, this is a quote, develop a statewide collection system containing data on healthcare charges, utilization. Let's see, let's get this little window out of the way. There we go. Healthcare charges, utilization, provider quality, and outcomes. It took effect on 9/1 of 1995. And the goal was to create a more competitive, financially efficient, and accountable healthcare system by giving consumers, workers, employers, and state policymakers access to data that could identify service utilization costs and expenditures. Now, I think the idea was that we would pass this in 1995, and in 1997, the golden Shangri-La of an equitable and easy to access and understand healthcare system would hit us. It did not. This was not a simple feat. This was not a simple tool to deploy. Only now are we beginning to see, especially from our insurers, right, the ability to look at costs across facilities. I was calling to get pre-authorized on an MRI, and the representative on the phone from the insurance company said, "That's great, you can go wherever you want, but by the way, if you go next door, it's going to be $100 less," right? That sort of information was the goal of House Bill 1048, which is now codified in public health, in the Texas Public Health Code under Section 108. Right, so we now have the Texas Healthcare Information Council, which collects all of this data. It's collected through the Department of Public Health. So what it is transaction level data, meaning every time that there is a transaction, and specifically their financial transactions, data is captured. It's based on the encounter level. So we're going to talk a bit, it's not just inpatient, there are some other data sources that are in there, but the unit of analysis is the encounter. So if I go to the hospital 10 times, that's 10 encounters. I'm in the system 10 times. And it has been collected quarterly since 1999. I take that back. It's collected regularly. It's released quarterly in electronic record level format. It has changed greatly over time, specifically as we've changed ICD 9 and now ICD 10 codes. The coding that we've used has changed, but the state has been really good about amending records that have changed. So for instance, this quarter's data update will have not only the new data for this quarter, but it will have amendments to data from past quarters. So I can update a record because we've got better data now, for instance. We collect data on 3 types of encounters, right? The oldest collection that we have is inpatient data. Now, the inpatient data collects data on all patients who have been discharged from the hospital since January of 1999. We'll get into a minute about what the data includes. So that's the oldest collection that we have, which means we have 22 years now of encounter level data from every person discharged from most hospitals in the state of Texas. It's not every hospital. Certain hospitals that are smaller and in rural areas are not included in the legislative mandate to report their data to the state. But for instance, the vast majority of hospitals in North Texas, and I would probably wager that it's all of them in Dallas County and Tarrant County, are reporting their data to the state. As a matter of fact, in North Texas, we have a unique arrangement. Most of the hospitals in the region send their data to the DFW Hospital Council. The Hospital Council puts all their data together and sends it to the state for them. Beginning in 2009, we started reporting outpatient data. Now, the outpatient data was limited at first. It involved only visits to ambulatory surgery centers that included invasive surgery or diagnostic imaging. So if you went to have your gallbladder removed, we have that encounter data. If you went to probably not your corner Envision imaging, but if you went to the hospital to have an MRI, we would have that data. Again, not all outpatient encounters, only those involving invasive surgical procedures or imaging. But in 2015, we started including all visits to the emergency department as part of the outpatient data collection. And in October of 2020, so just last year, which means we're not seeing the data yet, they started including freestanding emergency medical clinics. So your Care Nows, your Doc in a Box type places, that data is in there as well. Typically, again, why I say we're not seeing the data yet, the data is released by the state quarterly, and it tends to lag 3 to 4 quarters. So we won't see that October of 2020 data until probably, it should be in the December release this year. On top of that, the state, when they first start bringing data in, for instance, ER data in 2015, they sat on it for a year or two to make sure that the collections were good before they started releasing the data to the public. The last data set you can access is emergency department data. Now, the emergency department data isn't another submission from the hospitals. They actually just cull through the inpatient files and outpatient files. And they pull this based on revenue code. So if you look at the charges, there are specific charges that are related to emergency departments. That emergency department charge code triggers that data to be dumped into this emergency department file. So if you're just interested in, let's say, ER visits for asthma or breathing difficulty, they would be in the emergency department file. All right, so what's in the box, right? The great Ragu commercial. First, we have geography. Now I'm going to describe for you, there are 2 files, we'll talk about them in a minute, but I'm going to tell you about what's the public file. For each encounter, we have the patient's home state, the patient's home county, and the patient's home zip code. For each encounter, we have the patient's demographics. So we know their age, their sex, their race, their ethnicity. We know how much their visit cost, total charges. We also have their, this is where the data is extremely rich. We have their admitting diagnostic codes. This is an ICD-10 code that is very specific. So this is the diagnostic code for which they were admitted to the hospital. Somebody may, for instance, have coronary heart disease, but what causes them to be put in the hospital is an acute episode of syncope. So the admitting diagnosis would be syncope, but the principal diagnosis would be the coronary heart disease. On top of that, we have 24 other diagnosis codes that are included. So these are all of the illnesses that a person has. So imagine that person who has coronary artery disease or congestive heart failure might also have diabetes, might also have asthma. Now, there's to understand what's really going on with this data, you have to recognize the reason it is collected is to support billing operations for the hospital. This is how I get reimbursed from Medicare, or how I get reimbursed from Blue Cross, is submitting charge codes, and charge codes have to be supported by diagnostic codes. So a patient, for instance, may have some tertiary condition. They may have asthma. If it doesn't come up in their conversation in the ER, it's not going to be on the diagnostic code. Now, if they come in with breathing difficulty, you can bet that diagnosis is going to be in there. So there are 24 other diagnostic codes. We also have causes of morbidity that are included in this. These are the ancillary conditions, like was this injury caused by a car wreck? That's in there. We have the surgical procedures in the inpatient file. We have the surgical procedures they received by day. So we know what types of procedures they had done. We know the illness severity, it's actually coded according to a common scale, the same with the risk of mortality. And then we also have the bill amount by hospital unit. So I know for each patient, for each encounter, what they paid for room and board, what they paid for imaging, what they paid radiology, what they paid urology, what they paid pulmonology. So I can see what we're actually paying for respiratory services for these patients. That's the encounter level. And then we have the charge file. So tied to each encounter is the specific their bill, the list of charges that appeared on their hospital bill. So we have a revenue code that places it in someplace in the hospital, for instance, the emergency department, the pulmonology unit, et cetera. The procedure code that they received, units of service, charge per unit, and total charge. So if they received an albuterol treatment, breathing treatment, that albuterol breathing treatment is recorded in the charge file. And we know how much of it they received, what they were charged, and total charge. Now, I forgot to mention on the encounter file, we have the payer of their hospital bill. So we know which of these encounters are self-pay, meaning uninsured, which are insured by TRICARE, by Medicare, by Blue Cross Blue Shield, private insurer, et cetera. We also know how much they owe and how much was paid by the hospital. So for instance, we have used this data in our work with the United Way to take a look at what we're spending, what the state is spending on charitable care for different people with different diagnoses in different locations. All right, so let's talk real quickly, we're getting close to the end, about accessing the data. We've talked a bit about the public use data file. There's also a research use data file. Now, the research use data file and the public use data file have the exact same information. There's no records suppressed from the from the public use data file, but the research use data file actually identifies the patients. So instead of a home state, home county, home zip, I actually get a home street address. I can also link patients across encounters. Right now, if I go to the hospital 10 times in the public use data file, that's 10 people, as far as we know, went to the hospital. We don't know that they're the same person. In the research use data file, we can actually assess who is whom and how often an individual patient is using either inpatient, outpatient, or emergency department services. So the state, as you might imagine, has significant restrictions on this data. It's true for the public use data file and the research use data file. We are limited in where we can physically locate the data. It has to be located with the organization who is licensed to use it. In addition to that, it has to be used by named organizational users. So for instance, every student on my campus who wants to use the data has to include me on their project. Otherwise, I have to go to the state and actually appeal to have that person added as an independent user on our record. And importantly, it prohibits sharing between entities. So it's extremely protected because it is healthcare information. And for instance, even though the public use data file does not identify patients, it is a specific license violation, and there are civil penalties for going into that data set and trying to find someone. For instance, looking up when you were in the hospital and seeing if you can find your record. If you attempt to use this data to identify a patient, to identify a specific geography, et cetera, it's a significant civil penalty. Plus, your institution's going to get in a whole lot of trouble. Okay, so let's talk a little bit, one more thing. I don't have a button for it on here, but how do you get the data? The public use data file is free to Texas state agencies, state universities. It is also free to city and county government health departments. So if your city has a health department, your health department can request this data. I think we pay $25. I mean, they don't charge the rack rate. I think we pay $25, and basically when I put the order in, it used to be that when I put the order in the next day, it would arrive by courier. Now it's all moved electronically. If you are an in-state hospital or an in-state hospital, it's $3,000 a year. If you are an out-of-state university, out-of-state hospital, or a public company, it's $6,000 a year. So it's not cheap, but it's very advantageous to have someone who has free access to the data. The limitation I would suggest is if your city has a health department and that health department goes after the data, you can't give it to someone else, right? So you would have to be involved in the project. That's the only real caveat is your health department needs to have an analyst who can run the analysis. Even though you may partner with other cities, you've got to be able to run the analysis yourself because you cannot share the data with anybody else. All right, so opportunities for collaboration, at least as far as working with research partners at universities. We have done in the past collaborative research agreements. This was our work, for instance, with the United Way. With United Way, we looked at the emergency department file, and the Wagner School of Public Health out of New York University actually has an algorithm that looks at ICD-10 codes and determines how likely it is that that visit should not have been in the emergency room. So we're able to track over time how emergency department utilization is changing, right? We are seeing fewer non-emergent cases in the emergency room, but not a lot. I think our last estimate was somewhere between 10 and 13% of the volume of emergency room business is actually truly emergent, not preventable, not avoidable, not doctor treatable. We also go after grants. So if we're going after a grant, for instance, now with the National Science Foundation, that would create an analytical tool that would help analyze this data for people who don't actually have to have the data. Most of the folks that we work with aren't interested in really deep statistical analyses. They want to know what's the hospitalization rate for their zip code for asthma or for high blood pressure or things like that. So that's the type of work we can get grant funded. And then we have students, of course, who do research. And those students are always looking for a decent application. Now, at one point in time, we got calls every day saying, do you have a student that wants to work for free and do their dissertation? The university sort of frowns on students working for free. Now, that said, students don't have to work for thousands and thousands of dollars. A lot of times what we'll set up is like an internship. And as an intern, they have access to the data on our side, but can produce the report for you. So that's it. That's it in a nutshell. The long, sad truth of public health data in Texas. Actually, most of my friends in other states are jealous because nobody has this type of data collection. But it's buried sort of in the beast of state government, and you have to go mine it. Once you mine it, you can actually do a significant amount of analysis. And I'm happy to take any questions, Nick, or we can wait till later.
Thank you, Dr. Bray. We can definitely take questions right now for Dr. Bray. I see that there is at least one hand that is already raised. It was Jasik. Jasik, did you have something you were wanting to ask?
No, I'm good.
Oh, my apologies. So, Dr. Bray, I did actually have something that I was wanting to ask.
Sure.
So, if an entity here was wanting to partner with your agency or someone else who was doing this, how exhaustive is that process for getting someone approved as a user of this that is not actually a medical representative? So,
yeah, it's not about medical. The deal is I can't share it with anybody outside of my organization. It would basically be a new application process to go and create what they call a multi-entity license, right? So now anybody can get the data. There is no qualifications whatsoever as to, do you have a PhD? Do you have a stats background? Anybody can get the data. But if you're not a city or county government, one of the contributing hospitals, or a state agency or state university, you're going to pay for it. That's the real hiccup, right? It's $6,000 a year times 20 years is not now. I think I take that back. Up through 2009 is now freely available on the website. So if you want to just download the data and use it, you're still subject to the license agreement, but they've made it available. So the reason I suggest that is it can be useful to download it, play with it, see if the data will support the type of analysis you want to do. And then you go decide whether or not this is something you want to fork out $6,000 for to buy the data and run it for the last few years, or partner with some, again. So the deal, Nick, is like any one of your city governments can get it. They can't share the data with you. Now, and this is a question for THCIC, but I would think COG probably qualifies as a governmental entity, right? As a local governmental entity. And if that's true, you don't pay anything for it, right? In which case you can get the data yourself. And, we'd always be happy to just sort of ride shotgun and say, well, here's what we found when we ran that. But that's a conversation I would have with them, because they name cities and counties, they don't, and local governments is how the rest of it goes. So if they think that includes COG, then you're scot-free.
All right, awesome. Well, that answers a lot of questions that will be followed up as far as outside of this meeting that would be asked. And we have one question. Okay. All right. Well, did anybody else have any additional questions that they might be able to, that they might want to ask, or any implications for this that you might want to, you don't know if the data would actually assess, however, you believe it might. Kevin.
Just to clarify, I work for City of Dallas, Office of Environmental Quality. And so would I be able to get the data, or would I have to go through my city health department to get the data?
So it says city and county health departments. What's tricky with you guys is your health department is technically Dallas County.
Yes.
So I don't know if you would have to go through them, and then I don't know if they would let you have the data. See, this is the tricky part, is like if your health department requests the data, it is limited to use by your health department. It is not, they can't just pass it around city government and say anyone can run it. The health department can run analysis on it. That's one of the things we've run into at the university. I had a student who wanted to write a dissertation. I had to be on his dissertation committee and supervising it. Otherwise, it would have been a violation of our license. So he was allowed to run. We had to pull a subset of the data that met his requirements and allow him to run the analysis.
All right, thank you.
I want to give one other caveat, Nick, that struck me. So I mentioned earlier that the data is produced as a byproduct of the charging process, right? Of making dollars flow back and forth between hospitals and insurance companies. The net effect of that, it affects the accuracy of the code. So I'll give you an example. We went to run an analysis. The ICD-10 codes are extremely detailed. If you go into the code for a broken arm, you can get into, was it a broken arm from a car crash? Was it a broken arm from an incident of family violence? We wanted to see if the family violence data captured by the police department could be mirrored in the family violence data that we see in the hospital data, except there's none in there, because it turns out doctors are not inclined to, the hospital gets paid for a broken arm one way or the other, whether I say it's an accident, whether I say it's domestic violence, whether I say it's a victim of crime, or whether I just say not elsewhere specified, right? But if I say it's domestic violence, now the doctor gets called into court if there's a police charge or anything else. And so they're inclined to get paid, just mark it broken arm. To get paid, just mark it broken leg. Don't mention that it was in a car crash, right? So that's some of the byproduct is at your higher levels, the code is one of those nested codes like NAICS codes or SIC codes. At the higher levels of aggregation, it's really accurate. As you start to get into the weeds of all the things past the decimal point, it starts to get more spotty.
Okay.
I see there's a question in the chat on how does it account for uninsured population? So you're in this data if you were in the hospital, whether you paid your bill or not, right? The payee type for uninsured persons is it's basically called, I think it's coded charity care. But all of those folks are, if you were in the hospital and you were discharged, you are in that data set.
All right. So there were a few other comments in the chat that related to people who have used this in the past or additional data sets that might be of use. So these are awesome, guys. Thank you so much for everyone. And there was an additional question that was sent to me regarding, Dr. Bray, can you post into the chat somewhere the website for requesting access?
Yeah, I'll put that in the chat right now.
Wonderful, thank you. All right, were there any other questions for Dr. Bray? If not, I'll go ahead and we will swap gears real fast. Thank you, Dr. Bray, again. And so can everyone see the agenda screen?
Yes.
Wonderful. Thank you, Vivek. Trying to make sure that it's swapping screens correctly. All right. So normally we do the health data in North Texas update a little bit earlier before our first presenters. So with Dr. Bray talking about the inpatient health data, we wanted to kind of swap things around a little bit that way that this can directly go into kind of items that we touch on in our normal housekeeping. So with that said, we'll go ahead and swap over to the actual, all right. So with our, so this is a slide that all of us are familiar with if we've been to one or more of these meetings before this. And we wanted to just bring it back to reiterate the need for this health data and research on the air pollution implications on health. So a lot of what Dr. Bray just covered actually can be assessed from this, it sounds like, as well as a couple of the things that were written in the chat are things that we really should give some credence to and further guidance for talking to people who have used these data sets, seeing what we can do, because this type of research is very important and is the basis of why this task force was conceived. So this slide is particularly important because it is something that we could look at essentially, and it's an Orange PM day in our region, which those are extremely rare for us, as most of us know. And this was done in October of October of 2017. So using this data set, we could look to see if, oh, that did not change. We would be able to look at essentially what we're wanting to look at is this health data that is so difficult to obtain. We're wanting to look at the kind of pulmonary data at a very granular level to help with the extended analysis for these kind of existing conditions for helping out with public health and research implications. So a lot of our grant applications from now on are going to involve these types of things. And so having data sets of this nature actually would highly strengthen both the ability for procuring funding as well as deriving actionable information. So from here, so this covers some of the known sources of our data collection that we've addressed in the past. The bottom right-hand one is the one that Dr. Bray just covered, the Texas Inpatient Public Use Data File. That is a lot to say that quickly. And we're extremely happy that he just covered that because it sounds like something that from some of the messages that I've received personally, that this is going to be something that few people are actually very interested in for us to look further into. So I know that a few of y'all have already thrown in some data sources, but if anybody has any additional data sources or data sets that could help out with this type of thing, or contacts that we might be able to talk to that would have these types of either data sets or information to help us with either getting health data access or things that could be used to kind of hit the backbone of what we do here for this actual task force, then please feel free to message myself or Dorothy or really anybody at COG, and we would love to discuss it further with you. We appreciate the help that everyone has given so far, and this is all really great stuff. From here, just a couple more quick slides, and I'll be out of your hair and pass it on over to Eric. But so proceeding forward, we look to evaluate the PM exceedances and air quality, like air pollution and air quality implications, so on health. This channel channels the discussion towards, of course, the localized hotspots, and from that information, we can analyze the air quality, the data itself, in order to try to see how things are trending, correlations, research, like potential research areas. And of course, that means that we can go for additional funding and helping out with actually improving the air quality and livelihoods of the, well, not livelihoods, but the health of our populations. And as we were talking about particular matter earlier, I briefly just wanted to go over something really quick as far as the PM standards and where we currently stand. So this is a quick representation of our metropolitan planning area. So anybody who hasn't seen a graphic of this nature so far, this area is the metropolitan planning area that the COG serves. So most of the people in this call is actually within this region, and this is the area that most of our policies are intended to help support and better the lives of. So the PM standards are, of course, set up by the NACs, and we have these standards over here. The monitors range from as low as 7 micrograms per cubic meter up to 9. So as you can see in the top left-hand side for the legend, the kind of the green values, or those that are not problematic, are 0 through 12. So our current standards, as you'll see on this next slide, deal with a current annual averaging that looks at the annual mean average over 3 years. So for those of y'all who are very familiar with ozone and the design values, it's essentially design value aspects of things, just related to PM. So we have two different kind of standards within here, the primary and the secondary. The primary is set up for public health protection and the secondary is set up for public welfare protection. Public health is pretty self-explanatory. You know, public health, how does it affect people, pulmonary disorders, et cetera, et cetera. Whereas public welfare are things related to the nature of how are things with looking like visibility and how are I'm so sorry about that. Visibility and basically overall welfare of different things that PM actually implicates. So that being said, there was actually a PM 2.5 reconsideration, and they're reconsidering it as of June 2021. And so the EPA will be pulling up the current standards and reviewing them to see if they are current or need to be updated according to science and medical. And so it's currently at 12 for our annual averaging. If it were put lower, then we still are within our range of attaining that standard, so long as it's within about 9 or higher. If it is lower than that, then the good news is that this is just the draft. You can see that the comments are due for the draft proposal on December 14th, so that's coming up. But this is just the draft policy assessment, and then there is the actual rule proposal, that whole process, another area where you can do your draft comments. And the rule won't be proposed until 2022. It will be finalized in the fall of 2023. I believe it's the fall of 2023. And so that means that at that point, we're looking at, sorry, chats. We're looking at so with it being implemented in 2023, it'll be instated. You won't actually have to fall within those standards, essentially. Those won't become governing until 2025. So at 2025, you'll be looking at instating the actual NACs that would be in place for lower air quality standard for PM. And at that point, you'll be using the years of 2023, 2024, and 2025 to assess that. By then, as everyone knows, our air quality has actually been improving over the years. That is very, very thankful. We plateaued out for PM 2.5 whenever we did a quick assessment over it. We are doing further assessments over how PM 2.5 is in our region. And as far as it's concerned, it's looking really well. And by 2025, there should be a lot more projects that are implemented to actually help with attaining any future standard that would be put in place. So as far as it's concerned, we're trending very well. And if they lower the standard by all that much, we'll still be golden with the way that we are going currently. So with that, I'm actually going to go ahead and pop this over to the agenda really quickly to introduce our next presenter, who is Eric Kloss, who is the CEO and founder of Daily Breath, whose presentation is Personalizing and Localizing Asthma Impacts to Prioritize Clean Air Initiatives and Improvement. With that said, Eric, take it away, please.
Sure, Nick, thank you very much, Nick, and I appreciate this opportunity to talk to the task force. If you just want to bring up the slides.
Yes,
so today I'm going to talk about how Daily Breath is a mobile app, and what we're going to try to present is the idea of leveraging asthma impacts by individuals who have asthma in your communities to support their own personalized asthma care, but also to target clean air initiatives for vulnerable populations in your community. So next slide. So my name's Eric Kloss. I'm the founder and CEO and the innovator of Daily Breath. I have a background in health IT, digital health, and I'm a serial entrepreneur. This is my third startup. Over the last 5 years, I've spent about 10,000 hours in environmental health awareness. It's kind of the term I use for this emerging domain. And in that process, I've developed some expertise in areas that I never really even imagined: climate change, environmental factors, and then obviously respiratory health. And I kind of found my calling. My mission is that, even one life breathes easier while we all work to ensure a more breathable future. So next slide. So obviously everybody breathes, indoors, outdoors, in various parts of your community. But for many people, specifically those who are ultra sensitive, the air is becoming unbreathable in their community because of various environmental conditions, both daily environmental conditions as well as incidental environmental conditions. And we'll talk about that a little bit too. Next slide. So obviously these are primary sources of pollution, major asthma pollutants. You've got ozone, you've got nitric oxide, and then the wildfire smoke kind of represents PM 2.5. But obviously there's other forms of PM 2.5, dust particulates, everything from the Saharan dust that comes over the Atlantic to regular dust particulates, and then industrial pollution. So next slide. And this is just a thing that I use, to describe the problem. Every day in America, there's 30,000 asthma attacks. There's a high incidence, about 16%, or 5,000 daily ER visits. And there's some reasons around allergy and asthma gaps for that. And then 1,000 of those actually lead to, inpatient hospital stays of about 2 to 3 days because people can't recover their breathing. And then sadly, 10 people lose their lives every day due to an asthma attack. And I describe these as potentially preventable asthma attacks. They don't necessarily have to occur. We can detect early onset symptoms that are associated with exposures. So in the US, there's 25 million people with asthma. It's estimated about 330 million people around the world. But as I began to present this app to the market, there's 8 billion people who actually breathe, right? So there's various things that you can deliver through this mobile app. And they can actually, track environmental insights. What I realized was, that people, who are vulnerable don't have the insights to avoid triggers. Next slide. So based on some information that Nick and Dorothy provided me, it's clear that, asthma prevalence both in children and adults in the 16 counties is generally above average, not highly above average, but it's certainly a little bit above average. And Texas is somewhat unique in that you have allergens year round. You have trees, then you have obviously significant grasses and weeds. And then you also have this dynamic or phenomena of the mountain cedar trees, which create cedar fever, which from what I understand, even from a colleague who contacted me in Austin, he was already experiencing kind of the mountain cedar pollen allergy. And then obviously pollutants, ozone, seemed to be the largest issue that Nick was talking about was ozone, and then secondary being PM 2.5. And then, there's other pollutants that, really, this is an emerging area for asthma. We're just beginning to understand how these specific types of pollutants really impact asthma patients. Next slide. So I'm going to describe just a traditional approach to tracking air quality and pollen and weather and all that kind of stuff, and then the approach that I brought into Daily Breath. So there's traditional focus on the measurement of the pollution exposure itself, right? So there's various air quality indexes, air quality apps that are emerging that track a specific set of pollutants. And for the purpose of actually quantifying air pollution and tracking it and informing a policy and regulatory framework, that's really strong and really powerful. But what I wanted to try to do with Daily Breath was actually try to show that the people's experience of exposures in their daily life, the actual symptoms that they experience as they travel in their community, and how that's connected to air quality, the weather, and the pollen. So what Daily Breath does at its core is track symptoms, right? And by doing that, monitor what pollutants are impactful and where are those impactful as a person experiences their day. And this can be valuable, obviously from a personal level. I call it personalizing public health, but it's personalizing asthma care, right? It's basically providing a framework for preventative health action by the individual so that they can actually avoid asthma attacks. The ancillary benefit is that you actually identify pollution hotspots because you're basically tracking symptoms prevalence in a community. And I think longer term, because you're tracking these pollution hotspots where people, where vulnerable populations are having symptoms, you can actually target various parts of your community for immediate environmental remediation or climate change mitigation activities that will have an impact. Just imagine potentially putting a tree barrier between a highway and maybe a community that has more vulnerable asthma patients. Next slide. So at a core, this is kind of just describing what Daily Breath does. Symptoms are not like when somebody actually has to use a rescue inhaler, okay? It's actually early onset symptoms. Asthma patients tend to know what their signals are when they're starting to experience airway inflammation. And so what we're really trying to do is capture that early onset symptom and associate it with whatever exposure they're actually experiencing. And the idea is you're gathering real world evidence. We talked a lot about data at the early time, and what we're really trying to do is aggregate patient generated data that actually is for a specific vulnerable population, those people with asthma, and how they're experiencing the environment. Next slide. So what this ultimately allows us to do is potentially project a daily breath risk index. Essentially what I wanted to do is create a personalized framework for tracking environmental exposures. Basically every person has an environmental exposure footprint that's just as unique as your genetic footprint, right? And so there's a convergence of issues that come together on any given day, and we wanted to capture that as the daily breath risk index, as well as we have alerts within that will identify a specific exposure that you may be more vulnerable to and alert you on days when that particular pollutant is high. Next slide. Again, I alluded to this in my earlier comments, but the second unique value proposition with the app is that when you actually are tracking a symptom, you're not just tracking the what, but you're tracking the when, what time of day, and more importantly, the where. So this is an example of what's going on within the app. You're actually tracking on a community flare-up map where all people are sharing anonymously the location where they experience a symptom, right? And what's interesting about this to a certain extent is that it potentially can crowd sense where people in the community are having symptoms related to environmental exposures. I tend to think of this as kind of a Waze for asthma, right? You're tracking people's symptoms, and you're actually sharing those symptoms with other people so that they know, oh, these are areas where other people like me have had a symptom. Next slide. So again, I'm fleshing this out, but the idea here is to crowd sense to crowd solve, right? So we track symptoms of people who have asthma. And when I say vulnerable health populations, that can be people who have asthma, but it can also be people who have asthma in specific locations. We do demographics in the app where you're tracking race and ethnicity. age, those kinds of things. So vulnerable populations can be asthma, but they could also be the children. It could be elderly. It could be pregnant mothers. Obviously multiple people are affected by PM 2.5 and these other pollutants. A primary focus for me is, targeting health, right? Targeting really what I describe as self-empowered asthma care. And so we're actually trying to create a framework in the app. We actually tell people what the impacts of those various weather and pollutant and pollen issues are, and then what we make daily recommendations in the app. So what are the things they can do to potentially prevent themselves from experiencing symptoms. So the idea is that you're really targeting a group of people within your community specifically for these efforts that will reduce obviously their symptoms, but there's also a cost burden associated with having asthma attacks and ER visits and inpatient hospital stays. Again, crowd sense where people are collectively experiencing more symptoms related to higher levels of pollution, identify areas where potentially you can initiate environmental remediation activities or ultimately climate change mitigation activities. Next slide. So again, I'm very focused on kind of mobilizing for action. I mean, we have people within our community that are vulnerable from a health perspective to our changing climate, to increased air pollution. And so how do we mobilize for action? Certainly, as was discussed earlier, Daily Breath is very interested in communicating with local health departments, asthma educators, community health workers, school nurses. Actually, within the app, one of the things I added was an air quality flag, which is often used by schools to represent kind of the severity of air pollution in the area. But certainly, I'm trying to promote environmental health awareness broadly. And then obviously encourage people to download Daily Breath. But I'm also seeking really project opportunities with local governments, public health departments, academic medical centers around grant funding. Like I said, this is really an emerging area. The Biden administration, I think, is committing a large amount of money towards initiatives associated with clean air. So I really seek opportunities to collaborate with local entities. And as you saw with my community flare-up map, I'm very focused on trying to work on a community-based model where I try to gather more users in a particular area, and then we try to impact that population in that particular area by reducing ER visits, reducing the cost burden, and then at the same time trying to develop a model for we have a lot of things around climate change mitigation that people want to initiate, and how do you track the impact of that on a health population, right? And Daily Breath might be an opportunity to do that. So I think that's the end of my slides, Nick. I'm happy to, this is a little bit more. So the concept behind Daily Breath is pinpoint your triggers one symptom at a time. It's available on the App Store and on Google Play. Obviously, during mountain cedar allergy season, track symptoms to pinpoint your triggers. So I appreciate the opportunity, Nick, and I'm happy to answer any questions.
Wonderful, thank you, Eric. With that, does anyone have any questions for Eric Kloss?
Nick, can Eric, may I ask a question?
Yes.
Yeah, so Eric, very nice. Thanks for being here this morning and sharing your information. Is there, I mean, the data is only as accurate as the individuals that are reporting it, right? Is there any concerns you have or any validation that's kind of going on with regards to the data that's being populated into your system?
Yeah, so I did want to clarify. So I launched in April, so I only have about the benefit of about 6 months of traction, so to speak. But we have had the app downloaded in 140 countries around the world. I'm averaging now I'm close to 15,000 downloads. Ironically, a lot of people don't realize it, but very few download apps have more than 10,000 downloads. So, and on the back end, I've recorded about 1,000 flare-ups out of those. I have about 4,000 registered users right now out of all those downloads. So you've got the downloads and registrations. But in the back end, the whole point is really to offer the opportunity for people to input this information around their profile. I can't obviously require it necessarily. It's got to be an opt-in model. So that is a challenge. You know, you can put incentives for people to, you know, complete their profile and those kinds of things. But that is part of the challenge, is trying to get as rich a data set as you can, right, as you go along. But that's, you know, kind of why I'm starting this process of contacting local community, you know, organizations and stuff like that, because I really want to start on the front end of this, and really, as we develop our user base in a particular community, engage those community organizations in the process of engaging vulnerable populations, right? Getting them to input more data in, because, you know, there's a benefit to themselves personally, there's a benefit to the community health infrastructure, and then ultimately there's a benefit to the community from having this framework in place. Does that make sense?
Yeah, and I can see where crowdsourcing type stuff, the stuff that Dr. Bray talked about, which is actual, but, you know, even Dr. Bray indicated, just like we deal with, you know, accidents on the roadway system, they're not always reporting what might have been the specific cause, which, you know, I can understand. You know, there's safety issues you got to deal with. You got to get the stuff done fast. But then the data gets a little skewed in terms of what was the actual, you know, reasoning for the particular situation. But I think all this stuff can be overlaid, GIS based or something to, you know, kind of collaborate and hone in on what it is that I think the intent of the group is that Nick talked about earlier. You know, we've got these episodes, we're trying to see specifically transportation, and, you know, I'm not saying that if transportation is not a problem, then we shut this group down and we go off our merry way. But I hope in that what we're able to bring and evolve here, especially with your type of work, Dr. Bray's contributions, others, that others are looking at other sources that may actually be a potential problem, or that if we identify other sources that are potential problems, like if you're able to query, like after it's like, you know, from a statistical standpoint, you could, if it's when it gets populated comfortably, that you could do queries and identify, like what Nick was saying, hey, there seems to have been a lot of people reporting that they weren't feeling well. Let's go look at that day. Let's go look at the regulatory monitors. Let's go look at other monitors that the local governments are supporting, and see if there's something there that we can, you know, use as another like focus area to see what might have been the situation, and then what were the potential. And then we can kind of just see if we can't dive into it to back into what would the potential situations or upsets in the area that might have caused all that. And it's not just relying on one source. So you got a source. We've got individuals like Dr. Bray that's got sources. We've got monitors. This is shaping up. It's taken a while, but it's shaping up to be maybe a nice overlay of sources that might be able to you know, collaborate and support each other to then, you know, try to minimize the impacts that the citizens are having to deal with.
Right. Yeah. I mean, I've coined this word, this phrase, personalizing public health, and what I'm really trying to do is offer a tool for an individual who suffers from a particular condition, in this case, asthma, obviously plans to incorporate COPD and others, but, you know, support them as individuals in managing their own condition, but also provide a framework. And this is kind of where I think the opportunity is. Interestingly enough, Nick, you mentioned PM exceedance. And I think that's one of the various interesting things about, you know, what we have the ability to do with the app. We actually introduced a wildfire smoke tracker in August. And one of the reasons we did that was I was a little concerned about how we were framing wildfire smoke and air quality, in the sense that we were just having air quality monitors reflect kind of what that variable was. And I wanted to track atmospheric smoke as well as surface level smoke. So I have two models for that. And by tracking flare-ups in relation to those two models, you're beginning to understand what is the impact of those different smoke plumes. And I think that can help people understand what is the PM 2.5 exceedance from normal, from baseline, right? So when you actually have wildfire smoke events, how much worse is it, and how much worse are people experiencing flare-ups or symptoms in that community. So I think, like I said, I call it like the second inning of a 9-inning baseball game when it comes to environmental health awareness. And so I'm really seeking opportunities just to do exactly what you said, is make this part of the equation, real-time, real-world evidence related to people's symptoms that can contribute to public health, but also, personalized health.
Thank you.
That's awesome, Eric. Thank you. Great comments, Chris. So there were a couple of comments in the chat. One from Erin that she asks, does the app draw data from any environmental sources or monitors?
So yes, I mean, like I said, there's an emerging marketplace for air quality data. Companies like Breezometer and Ambi and various parties like that that include air quality monitoring in their networks. There's lots of networks that are emerging, like Airly, that has a strong network in the Europe area. Obviously, originally, my first beta version of the app actually connected to the AirNow air quality stations. I have to be honest, when I got into this domain, I'm not an expert in this field, so I was kind of surprised when I sought air quality data and pollen data that we don't have granular level data for those types of things. Breezometer and Ambi and companies like that have now come along with satellite data. But I think it's ultimately going to have to be a combination of both ground level air quality monitoring, as well as, satellite-based data that we draw from. Pollen is my biggest rub, because when I want to provide personalized health, and most of the pollen sources out there only track, 10 forms of tree pollen, right? I want to provide people a framework for understanding exactly what pollen affects them, right? And so that's one of my frustration, is there's not a lot of granular measurement of species level data. But yes, I draw from, whatever air quality sources I can. And like I said, we're very much early stage. So in a perfect world, I would love to be able to draw from that wearable sensor that's tracking the air quality, or if there's a fixed sensor that's nearby, that the user can be Bluetooth connected. I'm actually talking to an indoor air quality monitor company about how can the Daily Breath app connect to indoor air quality measurements to actually track if you have a symptom indoors, what's going on indoors from an air quality perspective. And obviously, with COVID, indoor air quality has become a major issue and a major concern. Hopefully that answers the question.
Excellent. Thank you, Eric. There was one other thing. Rock Robinson from eCara was wanting to meet with you offline sometime.
Yep, I captured that.
All right. Well, for anybody else, if there are any additional questions that might like to be asked, please go ahead and do so. If not, I will go ahead, and as you can see on the for the agenda on screen, the next presenter is going to be UTA. Dr. Mattingly is going to give us an update on our current air quality monitoring UPP, the University Partnership Project update. So if you could, Dr. Mattingly, it's all yours, sir.
And you just want me to share screen?
I can share it right here, sir. Unless you would like to.
You're more than
All
welcome.
right.
Okay, so I know y'all heard about the project before, and it's been a while, so there's going to be a little bit of review over what we're covering. One of the key things that's different about our work compared to the work that you've been listening to earlier today is we're focused more on the chronic health risks than the acute health impacts. And so next slide. So we'll be reviewing for y'all the objectives and the health data that we're using. And then we've created a nice little flow chart of the project to kind of show what we've accomplished thus far and how all of the pieces of what we've done kind of fit together. Then we'll show a couple of maps of some emissions that we've generated, and I'll talk a little bit about the heavy vehicle. We're still trying to get our analysis on that fully sorted out. And then I'll talk about what's coming up next for us as we move into the next steps of the project. So our project is really focused on the role that transportation emissions play in chronic health problems. And the health problems that we're targeting are high blood pressure, lung cancer, asthma, diabetes, lung problems, low birth weights, emotional problems, and headaches. All of these have been found to be chronic problems for related to air quality in some cases. One of the major steps, and primarily the phase that we've been focused on thus far, is all around this estimating household level exposure from traffic sources, both freeways and arterials. And that's what we're going to primarily talk about today. We're moving towards really looking at the relationship between the emissions exposure, confounding factors, and the resulting health problems. Next slide. So the health data that we're relying on in this study is the National Health Interview Survey. The data that we're going to be utilizing is going to be household level data. It's going to be scattered throughout the DFW region. And it's going to be focused on these chronic conditions that people are experiencing. The data we're going to be utilizing is from 2010 to 2018. That's going to increase the number of households that we have access to within the DFW region. And it also helped us address some of the privacy concerns that the CDC has in releasing the data for our use. In future studies, we'll be able to utilize some of these other data sources that NCTCOG is gathering and organizing to enhance what we're doing, and then any other relevant data that we can identify. Next slide. Okay, so I know this slide is a little confusing, so let me kind of try to orient you to what it's trying to say, and then we'll kind of go through the steps. The light blues are meant to indicate inputs. The medium blues are kind of the steps that we're engaged in or the modeling that we're doing. And then the dark blues are the outputs. So if we start up here over in the left-hand corner, we're starting with the TxDOT roadway inventory from 2018, which has average daily traffic, number of lanes, other geometric characteristics associated with the inventory. There's also some fleet mix data associated with the TxDOT data, but it's in selected locations throughout the the network as opposed to being on every link where we have ADT data. So one of the things that we did is we cleaned up the network, and we then had an emerging set of data that had cleaned ADT and number of lanes, which we took that as well as the fleet mix data, some land use data, and then also some data related to fulfillment centers or warehouses where we're looking at potentially a lot of truck traffic. We're looking at speed limits, number of lanes. All of that information is going to go into our fleet mix model. I'll talk about each of these modeling steps a little bit more as we move forward in the presentation. Out of the fleet mix, we're going to get this ratio or percentage of passenger trucks, single unit trucks, combination trucks on that link in the network. Separately, we're looking at the data that NCTCOG uses for running moves. And that includes fuel data, age distribution of the fleet. We also gathered some meteorology data that we used, and then had to come up with operating modes for the moves model. Out of that, we've generated different emission rates for vehicle types, for different seasons, and different hours during each day. All of this from each of our different steps is integrated along with meteorology data and receptors, which we selected as inputs into our line, which can then give us the exposures at each receptor within the DFW region. It's a lot of words. I'm going to have at least a few pictures to help try to clarify what I'm talking about here in a second. Next slide. So when we're doing the QA and the QA/QC for the network, one of the things that we recognized as we were reviewing the volume capacity ratios for some of the links is that they weren't very realistic. We were seeing volume capacity ratios of 2 and 3 and 4, which doesn't make a lot of sense. And so when we looked at the text.network, what we determined is that there were essentially 2 types of errors that were occurring within the system. One was an error that we'll call a longitudinal error, where there was a lane drop or some change in the number of lanes between adjacent segments. And the AADT that they had associated with a particular segment was captured from a previous segment, the upstream segment most likely, or potentially even the downstream segment. And it reflected the wrong number of lanes and AADT. So the AADT could be reflecting the AADT where there were 4 lanes, but now we were in a segment where there were only 3 lanes. And so we needed to try to figure out exactly what the correct AADT was based on the number of lanes that were present in that segment. Other type of error, and this one was far more common, was one where there were parallel facilities. And when there were parallel facilities, what we often saw was that they had the AADT for all lanes of the facility assigned to individual links or segments. So as an example, if we were thinking about LBJ, you might have both the managed lanes, you'd have the managed lanes as well as the main lanes all being having the same AADT value for all 6 lanes that were present on LBJ. So, and we saw that type of error fairly commonly throughout the network. There were probably about 1,000 links that we ended up having to try to address related to some of these errors. Next slide. So with the fleet mix estimation, what we were trying to do is we were trying to take the limited sample of fleet mix data that we had within the network and be able to translate that into a fleet mix that we could use throughout the entire network. And because there was no reason for us to, well, we tried to look at a simple linear regression model, and it didn't really work well because we don't really have a linear relationship between many of these variables. So we opted to do some tree regression models, and we found 6 different models, for passenger trucks, single unit trucks, and combination trucks for both freeways and arterials. And these trees are using average daily traffic, speed limit, number of lanes, and then land use variables. And the land use is based on a 1 mile buffer where we're gathering the industrial, landfill, railroad, other retail uses. One of the reasons why we focused on these is we expected there to be potentially different types of truck activity associated with these types of land uses. And then we also looked at just the presence of warehouses or distribution centers, really focused on distribution centers like an Amazon fulfillment center, a FedEx, or a postal location where we'd have larger amounts of truck traffic. Next slide. And here's an example of the results from one of our trees where we've got combination trucks on freeways, and we're splitting our data based on the number of toll lanes that are present. And the value that you're seeing there is indicating the percentage of trucks that are combination trucks. So the way that one of these trees works is you follow the decision nodes, which are these the orange nodes starting with the toll lanes, retail, number of lanes, fulfillment center. Those are our decision nodes, and then the leaves over here that have the at the very ends of each of these lines are representing the locations where the answers to the decision nodes followed a certain pattern. And the value that we see there is the value that's estimated, and it's just a mean value for the samples that are within that branch of the tree. Next slide. So with moves determines the emission rates based on the operating mode distribution of the vehicles on a facility. And we're using an operating mode distribution based on the average vehicle speed each hour. And we're borrowing the average operating mode distributions for freeways and arterials from a paper by Key. And in this paper, they created 10-mile-per-hour bands or bins to represent the average vehicle speed. And then they developed corresponding operating mode distributions that would be associated with those bands. We've grouped months to create seasons based on similar temperatures. And so that ended up with a summer season that covered June, July, August, a shoulder season that was September and May, kind of a hot shoulder. And then we had a cooler shoulder, fall, spring time period that included March, April, and October. And then our winter included somehow November, December, January, and February. I think that's just an indication of how warm our winters are starting to become, that November looks very similar to the more typical winter months. What we did is we took we calculated the average speeds for each of our links. We generated the fleet mixes. Well, we don't have to generate our fleet mix yet. So what we then did is we went through and we developed moves output for each of these different average speed operating modes, so that we'll be able to attach that to the actual observable vehicle speeds that we will see in a second. We translated our values into vehicles per meter so that we could generate a single set of moves output that then we could translate to all of the links network wide. Next slide. And so for the R-line input, this is where we're needing to calculate the average speed for each roadway for each hour. And so what we did is we took the ADT data, when we took the 24-hour distribution that NCTCOG has, and multiplied those together to generate our hourly volumes that we would see on each link. We generated the corresponding speeds using a BPR function for each of the links. And based on the average vehicle speed, we are then able to choose the appropriate moves output for us to multiply the total vehicles, which had been passed through the vehicle fleet mix, to generate our emissions associated with each link. Also, part of our input for our line requires us to place virtual receptors to measure exposure. And what we've done is we've used the TCEQ fine receptor placement. And there they recommend 100-meter receptors out to 1 kilometer away from the source. In this case, the source is the roadway. And so that's the set of receptors that we're placing throughout the entire DFW region. So what we did there is we created a 100-meter or a grid for Denton, Tarrant, Collin, and Dallas counties at 100-meter at a 100-meter grid pattern for placing receptors. Then the last set of data that we have to have is meteorological data, and that meteorological data is at the hour for each day. We're utilizing the meteorological data from 2018. And right now we have the data for DFW Airport from TCEQ. We also have the TCEQ data from a couple of other airports. And then we're working on finalizing some cleanup on some of the meteorological data from some of the other airports in the region. Next slide. So when we take a look at emissions, this is an example of PM10 between the summer case and the spring case, or the shoulder case for May and September. And we see some small differences that occur between these two seasons, with one of the locations being down in Tarrant County to the west of Burleson. We'll see along that, I think that's the outer loop that we've got in that area that connects in where we've got the Chisholm Park Tollway. We're seeing a slight change where they cross and slightly higher particulate emissions during the shoulder months. And we'd see more dramatic changes if we were looking at the winter case, because our particulate emissions are increasing during winter months compared to summer months. But overall, we can see that the freeways are certainly major sources of particulate emissions within the DFW region. Not a big surprise. Next slide. So for our next steps, we're going to be organizing our R-line output to aggregate the exposures present at each receptor. And then we also are working with dealing with with essentially a computational problem. R-line is capable of taking a certain amount of, generating a certain amount of output data with each run. And that output data is based on the number of links multiplied by the number of hours multiplied by the number of receptors. And while it can handle around 10 million, I think, I may be off a little bit on my numbers, but it can handle quite a few values for output. We're looking at the entire DFW region on a 100-meter grid pattern with all of the links involved for 24 hours times 365 days in a year. We're talking about an awful lot of data points. And so we're having to subdivide the region up to be able to process it in R-line. We're going to need to follow the same process for doing the arterials in the network. And then after we generate all of our exposure data, we will be merging that, sending it to CDC to merge that with the health data that will then be able to move on to phase 2 of our study and conduct that. So that wraps up my discussion, and I am happy to take any questions. We tried to have a little mix of technical, but hopefully not completely boring technical.
So much, Dr. Mattingly. That was very in-depth analysis on what all's going on here. And I know that that's just the top of the scale. So y'all are extremely busy over there, but it sounds like y'all are making great progress. For everybody else here, is there any questions for Dr. Mattingly or his team?
Thanks, Dr. Mattingly. Chris Kloss. What, maybe I missed it. The schedule that you're working on, when maybe things might be, kind of coming to closure and results that we might, again, I talked earlier about overlaying all this information. This would just be maybe another data set,
Right. So the emissions, the exposure side of things, we really expect to have that wrapped up in the next 6 weeks and have the exposure data all sorted out. So that is the data that will be easiest to share and is going to be, it's publicly available, easy. Then we're going to take that and we're going to fuse that with the health data. I'm not sure how quickly the fusing with the health data is going to go, and I'm not so sure how quickly that analysis will go. For the health outcomes and the health modeling, we will just get modeled results. We won't be able to share that data. That'll just be whatever we can bring with us as far as outputs out of the data center. But I would hope that by the time we have our next meeting, there should be a nice, wonderful map of exposures throughout the entire DFW region for everyone to be able to see what differences we have in different neighborhoods.
Okay, cool. Thank you.
Excellent. All right, making a lot of progress. All right, well, in that case, if there are not any other questions, then we will go ahead and swap back over to the agenda. And so that concludes the presentations for this meeting. Pardon me. And so I'm going to go ahead and open it up for other updates. So this is updates for everybody in here to bring to the table things that y'all are working on, things that y'all would like to work on, comments, considerations, all those sorts of things. Up first is actually the city of Plano. So Yarkis, are you on the line?
I am. Good morning.
All right, wonderful.
So you all asked me to update the air quality monitors project with UTD. So as a reminder, we've contracted with Dr. Larry at UTD to build and deploy 5 main unit air monitors that are being calibrated to federal standards. And the first 2 of those are built, and we've completed the cabling and the conduit needed for power and internet at 2 of our facilities. The first 2, one will be at the municipal center, and then one will be at a facilities center. And we hope to have those installed this month. So by the time we have the next meeting, the monitors should be on the shared air DFW map, providing readings for those areas that contribute to the regional readings. And next year, we will have the other 3 deployed and have the full 5 clusters of units deployed throughout the city. So we're happy to get those up and running.
All right, wonderful, Yarkis. Thank you so much. City of Dallas, Kevin.
Well, we're making progress as well, but we don't have anything. Well, excuse me. Sorry about that. We have our Breathe Easy Dallas project going, and it is coming to an end in December. Our partners at TTI will be looking at the data and drawing any conclusions and everything from that. So we're looking forward to that. We're also looking at it a little bit internally on a small scale. And so I think that's going to be interesting as well. In the future, we have a EPA grant for 5 additional monitors that we're going to place in the West Dallas area. This was a grant that was to study the correlation between air quality and COVID. I'm not exactly sure what form that's going to take, but we are also partnered with TTI on that. So they're going to be getting the monitors and helping us put them out, and probably be on the same data network that the existing data we have now on. And I will say that the Breathe Easy Dallas monitors are not going away. The grant project that was funded for it specifically is coming to an end. However, the monitors are still going to be in place and still going to be maintained. And they may be moved a little bit, but but the city will take them over, and the city will own those monitors. So we'll still have those monitors out as well. Plus, we have an additional grant from EPA, and we are putting out for bid up to 24 monitors to expand the network even larger throughout the city. And that bid should hit the street today, I think, that request for bids. And so we're looking at some monitors that are similar to the ones we have now, which are AirQual AQY, but we're also going to be adding a handful of slightly more sophisticated, more accurate monitors that we can deploy in locations around the city, strategic locations. So we're, moving along, and I don't know when that larger network will be in place. Like I say, we're taking bids for it now, or we should be starting to take bids for it very soon. But it still takes a long process to get that out and get it deployed throughout the city. So that's sort of where we are now. Hopefully by the time of the next meeting, I will have good news about the smaller West Dallas project that I can share with you guys, and hopefully have some information on results of our Breathe Easy Dallas program to share with you. That's all.
All right, wonderful. That's a lot of monitors that's going in.
Yeah,
and
it's pretty amazing, but it's somewhat intimidating to me that oh my gosh, what have I gotten myself into?
Oh yeah. And if I recall, for those who haven't had conversations with you, the difference between those higher accuracy monitors and then the lower cost ones that you're going to be installing, the higher accuracy ones you're going to be installing as kind of the primary monitors that are located variably across the city to kind of increase the actual scope of your monitoring network. And then the satellites are going to be used kind of as range extenders almost to kind of see how the data is and how it's correlating with those bigger monitors to help out with that. Was that correct?
Well, that's somewhat accurate, but I mean, I think more than that, obviously we can deploy more of the more inexpensive, the lower cost monitors. So that's the main thing, is we want to get those deployed in as many areas as possible. I think the ones that have the higher accuracy, I don't know exactly how we're going to deploy those yet. I think it remains to be seen, but those may go into areas that we think are more sensitive, where we need to get some more refined data. We have a couple of areas in Dallas that have long-term issues. That have longer-term issues that maybe we need some more refined data, some more accurate data in those areas. And I think it just kind of remains to be seen, but basically is it worth more to us? It's the question to me is it better to put out a lot of the small cheap monitors, or should we invest in a smaller network of more accurate and more expensive monitors? These monitors are still way less cost than the FEM and FRM monitors that are used for the network. So the grant had enough money to get both types, so we wanted to see what works best in our situation.
Certainly, that definitely makes sense. All right, City of Denton, JT, do you happen to be on the line? All right. It seems like the City of Denton might not be online.
I see his little box, but I don't hear him.
I do as well. He's not. I can't unmute him myself, so I can ask to unmute him, however. But given the case, he might have just stepped away for a moment. Well, we'll hear back from the City of Denton at another time, either later in this, at the end of the other updates section, or at our next meeting. That'll be next year. So in that case, it'll pop over to me real fast. And so let me share this back up again. All right, so we wanted to kind of just, as part of our other updates, bring to everyone's attention. Some of y'all might have already know about this, so sorry if that's doubling the efforts. However, we wanted to kind of bring this to everyone's attention, that the EPA announced 2 funding initiatives under their American Rescue Plan, which totals to around $100 million for usage on what they quote as health outcome disparities from pollution and the COVID-19 pandemic. So those are 2 projects. One of them is primarily focused on environmental justice, and the other one is focusing on enhanced air quality monitoring. So the environmental justice, it has a lot of additional parts underneath it, but the top funding, so the maximum amounts of monies, the top 4 are displayed here. So the first one goes to environmental justice grants. The second is tailored DARA programs to address environmental justice. The third was for monitoring enforcement in and around environmental justice communities. And the fourth is for brownfield sites, cleanups and redevelopment. Then the other $50 million grant is for enhanced air quality monitoring. Sorry about that. And the first one is for community modeling. The second is enhanced continuous monitoring of PM 2.5 and other NOx pollutants. So this is something that a lot of y'all are already doing as far as a couple of the updates here. Then the 3 was mobile monitoring labs and air sensor loans. So trying to outfit mobile monitoring labs or borrowing air sensors that you otherwise might not have access to. Then the 4th is monies that is dedicated towards administrative support. We wanted to kind of bring these all to everyone's attention. One, because some of us are already doing projects in relation to these, some of which you just heard, including which Kevin's West Dallas project is also one of these ARP grants. So that is something that you can see directly relates to it. And we just kind of wanted to bring it up front to everyone to kind of, 1, let everyone know, and 2, mull over at some point in time. Are there projects that you're wanting to do? Do you want to do the projects on as your own individual entity? Do you want to do collaborative projects between all of us? All sorts of things are available. something with that's right based underneath the Rice Committee. So there are a lot of different avenues to approach this, but we just wanted to bring it up and kind of let everyone know, and basically just field that so that people can make their decisions and we can open up that kind of discussion for later on. So the next part of this, let me get back to the agenda. My apologies, is the Lancet Countdown on Health and Climate Change. So the this will actually, well, the one that y'all have access to actually has the link that y'all can use for it. I can post the link in the chat later on, but essentially what the Lancet Countdown is it, I can actually pull it up for everyone real fast. All right, so it's for kind of an independent assessment on tracking the progress of health and climate change. So it's looking at climate change impacts, exposures, and vulnerability, adaptation, planning, and resilience for health, mitigation actions and health co-benefits, economics and finance, and the public and political engagement. So essentially what these are going to do are they're independent peer reviews that are posted into here for a lot of different papers and analyses that are done to kind of track where all everybody is regarding things going on with the Paris Agreement. So that's just something that we wanted to highlight and bring to everyone's attention. Do with it what you may, but I found it as kind of really interesting and informative. Then the next aspect is everyone here knows of the Air Quality Health Task Force webpage. The webpage has access to all of our previous materials, including recordings of these meetings, the agendas of them, as well as the slides. This meeting will be no different, and the slides will be presented, not presented, will be put online sometime next week, and along with the recording, and please use those informations as you need. They're always available, and if there's anything that we can ever do to either enhance or better incorporate the webpage, please let us know and we will be happy to abide and do so. The last thing that we wanted to touch base on was kind of give a heads up of next year's schedule. So as everyone knows, these are quarterly meetings and this is the last of this year's quarter. So the 2022 schedule will remain the same time frame, which is the 9:30 to 11:30 Central Standard Time. It will still be conducted remotely, and it will be held on Friday mornings. And we have February 11th, May 13th, August 12th, and November 4th. So just want to let everyone know about those in advance, and calendar invites will also be sent out before the coming next year. All right, with that being said, I will revisit City of Denton for the other updates in case JT is back. JT, are you happy to be back to present that? And as such, I will go ahead and ask if there's any additional questions, comments, or considerations that anyone might like to voice, then please do so. All right, in that case, we are going to get done with this meeting about 10 minutes early. I did not see anything in the chat. If anybody else saw something I did not, please let me know. But in that case, the meeting will be adjourned. I'll stay on for the next few moments, but that is everything. Thank you everyone for your time, and I hope you all have a wonderful weekend.
Thanks, Nick. Great meeting.
Thank you.
All right, I'm going to go ahead and stop recording at this point.